Okay, perfect. So my name is Debraj. I'm one of the chief residents at the University of Alberta in Edmonton, Canada. And I'm very happy to be here presenting a case on behalf of my mentors, Dr. Kevin Beatty and Dr. Wayne Timchuk. And so my case is titled Multivessel and Left Main Intervention in a Patient with Severe LV Systolic Dysfunction and Anomalous Left Main off the right sinus of Valsalva using Impella CP support. So to start off with our case, we have a 59-year-old Caucasian man. He's a type 2 diabetic, a smoker, and has established peripheral vascular disease. He comes in with a 3-day history of nausea and chest pain. His exam is consistent with heart failure. He has an elevated jugular venous pressure and bilateral respiratory crackles. He has a mildly elevated troponin I. His electrocardiogram shows anterolateral ST depression. His chest X-ray confirms our suspicion of moderate alveolar pulmonary edema. And before he went on for cardiac catheterization, the decision was made to start with an MRI just to see his LV function and determine if there was any viability to begin with. So he went for his MRI, and what they were able to show is that he had a severely dilated left ventricle with an ejection fraction of 14%. But he did have established viability, and what the MRI also showed was that there was an anomalous coronary circulation with the left main arising from the right sinus of Valsalva in a non-malignant course. So he was stabilized, diuresed, started on optimal medical therapy, and then taken to the cardiac cath lab the next day. So this is a shot of his right coronary. That run a couple times. And then the RAO view. And what we were able to identify is that from the RCA shots that he had a right dominant system, and he had a significant 90% lesion that was present in the mid vessel, just identified by the red arrows here. And then given the cardiac MRI findings, we continued using the JR4 diagnostic catheter to identify the left main. And we can see it arising from the right sinus of Valsalva there. And the main things to highlight here is that the left main originated very close to the ostium of the right coronary artery, although it was a separate ostium. And there was an 80% tubular lesion that was present in the left main. And then there was diffuse disease present throughout the LAD as well, with a 70% lesion present proximally and a 90% lesion that was present in the middle of the LAD. So I was taken off the table, and we went on to have a heart team approach for the patient. And so he was reviewed and then ultimately declined by our cardiac surgery team for being too high risk given his LV dysfunction and poor targets for grafts. And so he was accepted by our interventional team for high risk intervention using a protected PCI approach using Impella. And so he went back a few days later and then had the Impella inserted. That went through the left groin, and the placement was confirmed both fluoroscopically as well as with echocardiographic guidance. And then we started with the right, and it was wired successfully, actually pretty straightforward wiring with a BMW wire. And ultimately required 3 stents being placed. And I'll go into the details of that just right after I show you the final result here. So this is after 200 mics of nitro being inserted in 3 drug-eluting stents. The specific stents that we did use we used a 3x38 Zion stent in the mid vessel, which is the green arrow here, followed by 2 separate 3x38 and a 3.5x33 stent to the middle to the proximal area of the vessel. And so ultimately had a good result there. We continued using the JR4 guide to cannulate the anomalous left main there. And we're able to wire down past the left main into the LAD. And this was the final shot after the PCI was performed, and go through the details of that just in the next slide here. So we used the JR4 guide, and the anomalous left main was engaged and wired again with a separate BMW wire. We were having very tenuous guide support, and so there was a guide liner that was inserted into the left main using a balloon anchoring technique. And then the left main itself was opened with a Zions 3x23 stent. Then we moved on to the LAD, and the LAD itself required 3 stents, so 2 3x38 stents to the proximal and mid LAD, followed by a smaller 2.5x12 stent to the distal LAD. Now, with the Impella support, the patient was hemodynamically okay, but we weren't able to wean the Impella in the cath lab. He was in a persistent state of cardiogenic shock, and so he was transferred back to our coronary care unit with the Impella device in place for the next 8 hours, and then was subsequently weaned, and then the device was removed. He was discharged 8 days after the intervention took place and continued on dual antiplatelet therapy. We recommended going with a prolonged DAP strategy with aspirin and ticagrelor for 30 months, and his clinical status remained stable for the next 30 days afterwards. And he underwent for a repeat cardiac MRI, which we have the results for now, and his EF had improved from the 14% up to about 40% actually, so quite substantial improvement in LV function. And so what we were able to conclude from this case is that in a high-risk patient population, protected PCI using Impella CP support really remains valuable, and it should be considered in patients with multivessel and left main coronary disease with severe LV systolic dysfunction, particularly when they're not candidates for cardiac surgery. In this setting, we had percutaneous revascularization of an anomalous left main, and although the hemodynamics were tenuous, the Impella CP support provided us adequate hemodynamic support for a successful outcome. And to our knowledge, this is the first reported case of Impella CP protected PCI in an anomalous left main off the right sinus of Valsalva case, and in a patient with severe LV systolic dysfunction. Thank you.
Great case. You know, I think it's funny, most of us in our practices now are seeing the patients that would derive the most benefit from bypass surgery are not candidates for bypass surgery. And unfortunately, that's institution dependent in terms of the surgeon's level of comfort. But you would think that, you know, a young man like this, 55, right?
59, yeah.
59, they should be able to get through with this. But that was an outstanding result. I think it certainly shows you the utility of Impella support for these high-risk cases. I think one comment I would have is, in a lot of these cases, when they're this decompensated, we'd put in a swan early before the case, help guide that tune-up process. So you're bringing them to the lab when they're not really It's hard to know some of these patients, you know, what their cardiac output is, what their filling pressures are, and plus you have that during your case as well and after the case. So you may have been able to get the Impella out sooner if he was tuned up a little bit better up front. And I also am a little bit jealous that you guys can get cardiac MRIs as quick as you can, because that's not real world for us. And an echo is, you know, next day at least, but an MRI will take a while in our institution at least. So.
Yeah, I'm curious to know what was the reason for getting the MRI initially?
I think the thought process was that because he was a late presentation, he had about 3 days of ongoing chest discomfort and nausea, that they wanted, they wanted to know viability, particularly in addition to LV function prior to proceeding. And it was also at the time, because it essentially came on a Monday, and Tuesdays usually are surgical rounds, and so we had the information for the surgeons as well, and so it kind of expedited that. Otherwise, their next step would have been to ask for a viability assessment.
Yeah, well, that was great to have. One, because to have the viability, so you know what potentially your options are for the patient. But in this case, more importantly, is to find the course of the left main. I'm curious if the decision would have been different had the left main been intra-arterial.
I would hope so.
Yeah. I would say definitely. Yeah.
What you mentioned with surgeons, I think a lot of us are feeling that we're getting a lot of higher risk patients and taking on the cath lab. One consideration is this guy was a diabetic. Is if there weren't conduits, or they wanted to make the surgery not as prolonged, as you could evaluate for a hybrid, getting a Lima, the LAD, survival benefit, and then just come back and deal with the right at some other time as a consideration. But I
think that particularly would have been helpful if you did have a intra-arterial course, because I think putting a left main stent in a left main between the PA and the aorta is certainly fraught with potential risk. And so in that setting, you could do potentially an off-pump Lima at relatively low risk with probably hemodynamic support, and then fix the circ and the right percutaneously would have been a nice option had he had an intra-arterial course. The last thing I'd say is guide support in anomalous left coronaries from the right can be challenging. Actually, it's challenging for any anomalous coronary. But I think one of the things that you guys did that made it successful is having the guide extender. Multi-purpose catheters work very well because they kind of point directly down into the root. That's kind of my guide of choice in anomalous circumflex or left mains coming from the right side.
Yeah, and if you have trouble engaging a guide, the trick of using your diagnostic that's a little safer and softer to get in there, wiring through that, anchoring those wires, using a long wire, maybe something like a long wiggle wire, exchanging that out, and then getting a guide catheter up through that, or 2 wires too is another option. So.
Now, you decided to leave the Impella CP in, and then how did you go about weaning the CP and then making the decision of when to pull the support device?
It was just based off hemodynamics, slowing down the Impella, and then just following his lactate and making sure he had adequate urine output. He was maintaining appropriately, and then we just kind of pulled the trigger, pulled it at the 8-hour mark, and just watched how he did.
And did you have a right heart cath in to follow?
We didn't. We actually didn't. No, there was no Swan insert.
Well, I think a couple things now, and I think Matul said this, is having a right heart cath in can really be valuable, because oftentimes the systolic and diastolic blood pressures in this situation do not always tell you the whole story, and so having filling pressures can be helpful. Also, with the new Impella device that gives you real-time LV-EDP can sometimes mitigate the need for the right heart cath. Can be very, very valuable in kind of guiding weaning and discontinuation. The thing you don't want to do is discontinue this too soon, because the worst case scenario is in the middle of the night the guy goes into shock, and then you're putting another device in. It's obviously suboptimal. So.
Yeah, great result. Good job.
Yeah, thank you.
Excellent case.